Hi, I'm Dr. Emil Lesho, an infectious disease physician and healthcare epidemiologist at Rochester Regional Health. I'm here with my colleague and co-author, Dr. Lagio Vila, and we'll be summarizing our article, which will appear in the June edition of Mayo Clinic Proceedings. The article is entitled The Slow Motion Catastrophe of Antimicrobial Resistance and Practical Interventions for All Providers. I will summarize the first half. Dr. Lagio Vila will summarize the second half. All of us depend on a pool of effective antibiotics, all patients and all providers, regardless of specialties. Sometimes we take for granted that is antibiotics which have catalyzed practically all modern developments, all the miracles of modern medicine. Without antibiotics, we can't do elective surgery, we can't do hip replacements, we can't do transplant infections. So we must preserve these. And the crisis is defined by the increasing prevalence of drug-resistant infections. The World Health Organization, the CDC, both the United States Centers for Disease Control and Prevention and the European Center for Disease Control and Prevention, along with the Infectious Disease Society of America, state that escalating resistance to antibiotics poses one of the greatest and most urgent threats to global public health. The first part of the article summarizes the costs, both the human costs and the economic costs, which according to some experts are predicted to be upwards of 700,000 deaths due to antibiotic-resistant infections and potentially $100 trillion in economic damage. The second part focuses on the causes and contributing factors to the crisis. And we break these down into bacterial factors, antibiotic factors, human factors, and diagnostic and surveillance factors. I will point out a few of the less understood ones, perhaps. One is the nature of the crisis itself. Unlike Zika or Ebola, which have sometimes explosive outbreaks and dramatic consequences, antibiotic resistance is subtle, more slow-moving, so it's easily underappreciated. It can be eclipsed by bigger, more dramatic problems, such as the ones I've mentioned. Antibiotic factors include the dry drug pipeline. Pharmacy companies are disincentivized for many reasons to develop new antibiotics. And once new antibiotics are developed, the bacteria quickly become resistant to them. They then have the ability to easily spread those resistance mechanisms among other species and genera. Human factors include overprescribing of antibiotics, using antibiotics excessively in agriculture, highly mobile or displaced populations, and we're seeing that right now. We have some of the highest amounts of displaced populations, and declining vaccination rates. And finally, we lack rapid point-of-care diagnostics that can help us decide whether or not a febrile syndrome is due to a viral infection or a bacterial infection or something else.
I'm Dr. Lagio Vila, and I'm the Antibiotic Stewardship Director for Rochester Regional Health. So I'm going to discuss the second part of the paper in which we illustrate the many opportunities that healthcare providers across the spectrum can be antibiotic stewards themselves. We broadly categorize these opportunities as either being issues of minimizing overdiagnosis or minimizing overtreatment. So to talk about minimizing overdiagnosis of antibiotics, it's important to remember that we need to culture wisely. There are many conditions in which a culture may grow an organism, but that organism may not reflect that it's a true infection. For example, asymptomatic bacteriuria is a very common and benign condition, particularly in the elderly patients. If we test their urine cultures, we're likely to find an organism, but that doesn't mean that they necessarily need antibiotics. Another example we cite is C. difficile. C. difficile can colonize up to 10-15% of individuals. If their stool is tested inappropriately, where they do not have signs of colitis, yet they are colonized, the test will be positive, and they are at risk of getting antibiotics unnecessarily for a condition that is just colonization. So choosing when to use these diagnostic tests appropriately are very important, and we must think before we prompt the microlab to try and identify what may be involved. It's also important to recognize that there are many conditions which can appear like an infection, such as rheumatologic disease or other inflammatory conditions. Also, there are infections that don't require antibiotics, such as viral infections. Viruses are some of the most common reasons for upper respiratory infections, pharyngitis, exacerbations of COPD and asthma, and it's important to recognize that antibiotics do not treat viruses, nor do they have positive effects on these conditions. In fact, they often have negative ramifications for the patients, whether it be adverse side effects or promoting further antibiotic resistance. The second opportunity that we talk about is in minimizing overtreatment with antibiotics. Opportunities for this may be in if a patient does indeed need antibiotics, reassessment during the course. Is there any information that you've gained, such as positive culture results, in which you know you can narrow antibiotics from broad to narrower agents or oral antibiotics? Also, in being cognizant of what the national guidelines are for recommended durations of therapy. There's excellent literature describing that shorter durations of antibiotics are not inferior and at times beneficial compared to longer durations of antibiotics. So being aware of the new literature for shorter durations is something that we should all be cognizant of. The third thing that we say is an opportunity is being promoters of stewardship, not only among our patients, but our fellow providers. Patient education is integral to understanding the factors in why patients may want an antibiotic or have a misperception that an antibiotic will make them feel better. So taking the time to educate them about their condition, as well as the negative effects of antibiotics, will be necessary. We should also champion providers among us that are good antibiotic prescribers, because we know that if there is an antibiotic champion among a group, others tend to follow suit, and the culture will continue. Last, as Dr. Lesho had mentioned, to be vaccine champions. Vaccines have been integral in preventing serious bacterial as well as viral infections. So primary prevention of the bacterial infection is the best way to avoid unnecessary antibiotic use. In addition, viral infections that are prevented by vaccines also help to prevent conditions in which it may seem like an antibiotic is necessary. So in our article, we try and outline opportunities which will be seen by nearly everyone across the healthcare spectrum, whether they're in the outpatient setting, inpatient setting, critical care, urgent care. So thank you for your time.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.